Everyone. I think it's almost lunchtime, but I'll try to see whether I can make it an interesting topic. Almost in the past 35 years of my practice here, my passion has always been the treatment of acute heart attack, the role of golden hour, and having established the center with emergency angioplasties and all, which we have started in 1996. Now the current buzzword is sudden cardiac death. That is not allowing us to intervene in time or things happening within minutes. So this is what we have been seeing almost very regularly. You see a 23-year-old girl walking suddenly, on a function. Similarly, this happens at almost all ages. And without any symptoms, without complaining of any chest pain, patient suddenly drops. This is how, these are the things. And this gentleman who was walking suddenly collapsed. And then he was found to have multivessel critical disease. And these are the other, almost daily we are seeing. Yesterday also, 36-year-old person. So without giving a didactic lecture, I thought I request you to also put thoughts on this and see how the concepts have evolved in the past decade or decade and a half in thinking or in the pathophysiology of atherosclerotic process. And is there a way to identify the disease early and prevent sudden cardiac deaths? The in-hospital mortality, in-hospital complications by tele-ICU, that is a different topic which I'll be addressing later, which is also very, very fascinating and interesting, where you can definitely give good outcomes. So how many of you think, we have been listening a lot of debates, cardiologists, commentaries and all. Oh, patient had COVID, a few months back or a year back. Or it is vaccine related. And there is no other topic in the past century which has created so much of confusion other than the COVID disease. Where from it originated, what is the treatment modalities, different types of drugs, comments, a lot of, what has happened now with us. And how many of you feel that the deaths are preventable, the ones which we are seeing daily and all these things? See this. It's not the last 1 or 2 years where the celebrities suddenly drop dead, who were in the gym doing a lot of exercise, and then suddenly, linking it to some disease process. But all these things have been happening for the past centuries. Even Egyptian mummies had coronary artery calcium, and coronary artery disease and acute sudden cardiac death are not uncommon. And you see, this gentleman is Nitu Manke, one of the eminent surgeons at the age of 55. And he made 10,000 hearts stop and beat again. He operated 10,000 cardiac surgeries, and the current Kokilaben hospital was built by him. But before it got inaugurated, unfortunately, this cardiac surgeon was admitted with mild chest pain in the morning. So it was mild heart attack, and at 2:30, probably, I think there was some lapse of few hours, he had a massive heart attack and he died. Now we know the treatment. We don't leave the patient for so many hours whenever somebody has got a heart attack. The treatment is entirely different, but that was in 2003. And then, all these actors, and then, the other gentleman, the Ranjan Das, who did this gym and the buildings, and then while coming, he suddenly had death. And, Shane Warne and all these physically fit guys at different ages, how they are dying. And this is not new. 1984, he's Jim Fix, who was a marathon runner. He used to run 10 miles a day. And he wrote a beautiful book, The Complete Art of Running and How to Keep Yourself Fit. 10 miles he ran, and then again he dropped dead. And he was found to have triple vessel disease. For several years, he was running 10 miles a day. He never had any symptoms. He bet his sister on tennis one day prior. So he played tennis, he ran. On the other hand, you have this other gentleman, Winston Churchill, with all vices, food and all these things, he lived up to. So what I mean to say is the coronary artery disease, after my almost 35 years of practice here, still it is, coronary artery disease is an enigma. Whatever knowledge that has accumulated, whatever delays that have happened in adapting to the technology, thinking of or understanding the pathophysiology, unfortunately, certain areas are neglected. But still, even now, if I can't strike a diagnosis, I get worried that I am missing something, unless it is very, very obvious. So it remains an enigma, and a lot needs to be learned, which I'll be showing you where are the issues. The magnitude, everyone knows that Indians are afflicted at much younger age. We are, more than a decade and a half compared to Caucasians. Now, almost 50% of the heart attacks occur before the age of 50 years. And, the burden, financial burden, huge burden. But then, thousands of cardiologists, physicians, people, media, the perception of the atherosclerotic cardiovascular disease, by which we mean stroke, brain stroke, peripheral vascular disease, or coronary artery disease, how these events happen and how to identify the symptoms when the patient's present, or how to identify the hidden disease. The patient comes for something else. He's 45-year-old, 50-year-old, and you are leaving him, and next day within 24 hours, he comes with a heart attack. He was having disease for 15, 20 years, but we have missed. So the perception and a lot of things, a lot of knowledge is pouring in and related to socioeconomic status, and the newer things coming, genetics, epigenetics, the factors which control this. And then there is no other disease or treatment pattern which is taken so lightly, and individuals have their own perception and understanding and accountability. Accountability, we have been watching, many patients are seen, and then misdiagnosis is one of the most, litigation-related process which happens all over the world. And the screening methods, all of us have been using a lot of screening methods, and how the variance in interpretation of the test results, and then resulting in mistrust in the patients, then the inequitable resource utilization, because some people get over investigations, over medication, and really desirable people or deserving people do not have this. So then what do you think? Whom do you blame? Is it the uncertain nature of the ASCVD, or biases and too many debates, egoistic arguments by physicians, cardiologists, and patients, arrogance, denial, all these things? So the perceptions are quite different. And now healthcare industry is, industry 4. Unless all of us are updated, no doubt medical profession is a noble profession, and we cannot think that we are gods. We are just providing service. We are service providers. And in fact, customers are gods. So unless we are updated and we deliver the right thing, we are not doing our job. And with the explosive knowledge which is happening, we have to be, we have to keep running to stay where you are. So just to understand, and many of the things, as I mentioned, still are not totally proven, but in the process of acquiring more knowledge, I thought, all of us know diabetes, it is whenever we see a patient, we used to tell, oh, diabetes, the time bomb. Suddenly, silent heart attacks can happen, right? It is equivalent to a person who has got already a heart attack. So how many of you believe that diabetes patients are, it is equivalent to CHD disease? Then a lot of buzz on LDL cholesterol, the triglycerides, and then a lot of controversies on debates on statins. So what is the scientific evidence, current scientific evidence? How much of weightage you have to give to LDL cholesterol and triglycerides? And then what is the level you have to achieve, the target of LDL level? Is it uniform in every person at every age, or is it different? And when you bring it below 70, is there any, ill effects or neurocognitive impairment or diabetes or whatever? And then there has been many physicians must be there, many general practitioners. You must be treating hypertension. Everybody treats hypertension. It is so common. And then there is a lot of debate about, ASS, Ramipril, Lisinopril, Enalapril, which is better, and or telmisartan, isilsartan, or olmesartan, and all these drugs, which is good. A lot of debates on this. So ultimately, what is the final data that is available, and how many unnecessary debates and other things have been happening, especially in the field of cardiovascular medicine? And then this is another one. How many of you feel that the plaques, aortic plaques and coronary plaques start even at the age of 30 years? And what percentage have this? And many patients who are admitted with heart attacks, so they have, the traditional major risk factors and 200 minor risk factors. But most belief is, yes, at least majority of them have one or two major risk factors. So how many of you believe that it is true? Then we have been doing a lot of invasive angiograms, since 1990s and all. And when you do the invasive angiogram, when you see a 30% lesion, 50% lesion, 80% lesion, our communication and counseling to the patients has been, different for each patient. So how many of you believe that 70% of the heart attacks occur when the lesion, because you must be seeing the invasive angiogram reports and all, believe that the majority of the heart attacks happen when the stenosis is more than 50%. And silent myocardial ischemia, in diabetics, in patients who have had a heart attack, silent ischemia without any obvious symptoms, if you do treadmill or if you identify with a stress thallium test or myocardial perfusion imaging, or if the patient has got a positive FFR, but still patient doesn't have any symptoms. So how many episodes? It is an unaddressed, unattended, and improperly understood topic even now. And we know the lesions are very common, and we have been doing angiograms. And when we report 30%, we say, okay, go ahead with the lifestyle modification and all. How many of you feel that these are sufficient? And comes to the most important part. Ischemia stress test. All over the globe, millions and millions of ischemia stress tests. Either it is an exercise ECG, myocardial perfusion imaging, dobutamine stress echocardiogram, or dobutamine MRI. All these tests, how these are being utilized, how these are helpful. And we have been advising based on the mild, moderate, positive ischemia, severe ischemia. So patients should go immediately for bypass surgery or angioplasty. So what is the current evidence? How many of you believe that it is absolutely true and right to advise? And then in US, majority go for a myocardial perfusion imaging. Almost every 2 years also, many times it is done. And then coming to the other buzzwords, coronary artery calcium and CT coronary angiogram. In the past decade and a half, a lot of information has poured in. Similarly, lot of confusion also has crept into the practicing physicians, people, and everything. And how many of you believe that if there is patient has got hypertension, diabetes, is a smoker, hypercholesterolemia, family history, is there any need to go for a CT angio, or directly we should advise the patient for invasive angiogram or ischemia stress testing? So how many of you believe? And also, the higher the calcium, the worse the prognosis. And comes the most important part, which has been debated for, almost decade and a half, and a lot of misconceptions. In stable coronary angina, like, for example, you see a patient in your OPD, patient comes with stable angina. When he walks for about 15 minutes, he gets chest pain, and on rest, it settles. So what advice do you give? Do you directly send the patient for invasive angiogram in stable coronary artery disease? And then acute chest pain. Acute chest pain is a very difficult topic. Unless the ECG shows absolutely clear evidence, any chest pain in India, especially more than 30 years, I get worried if I can't get a proper diagnosis, either by ECG, echocardiogram, or other investigations. So the standard we have been using in 1988, when I started, we used to have chest pain units. Any patient we used to admit 24, 48 hours, we used to give heparin, aspirin, and all, treat the patient, control hypertension, diabetes. Then we used to subject the patient for treadmill test, or based on that, we used to go for invasive angiogram, advise invasive angiogram. So now, how many feel that still that is the standard of care and cost effective? And many times nowadays, CT angio has become, say, calcium scores. Many of the practitioners must be seeing, you may be seeing around 10 calcium, 5 calcium score, 1,000 calcium score. So are you worried when you see 10 calcium score in your own patient? And if calcium score is 0, so power of 0, you must be hearing us, oh, calcium score is 0, so I'm fine. So how many of you feel that if the calcium score is 0, you need not do any further investigations and, okay, let the patient take the medical management? And also, if the calcium score is high, you should not go for CT angiogram, direct invasive angiogram. That is the other notion. And another important thing, even patients, when we advise CT coronary angiogram, they say, no, but anyhow, I have to go for invasive angiogram. That is the, what is the thought process which has crept in. And how many of you believe that 50% of the patients need invasive angiogram who have undergone CTC aging? And how frequently you have to do CTCA in diabetic patients? And statins and blood thinners, aspirin, the controversy, the debate, the recent data. So should these be given to all the patients if there is one risk factor, 2 risk factors? What are the criteria to select the dosage and the type of medication? All statins and antiplatelet drugs should we do? And also post-PCI patients. And starting statins, you are hearing about the complications, side effects of statins, diabetes, neurocognitive impairment. And so if you start at younger age, that can cause, side effects. Avoid statins as much as possible at very young age. How many of you believe that? And then the other important thing, which is prevalent even among physicians and medical community, and which was propagated for wrong reasons, whatever it is. How many of you believe that CT angio gives more radiation than invasive angiogram? And how many of you feel that concepts are very clear among cardiologists, CT surgeons, that if we see a triple vessel disease or a multivessel disease or left main, the concepts are very clear, the data is very clear, so we can segregate the patients very easily. How many of you believe that the data is very robust? And you must have heard about CT-FFR, fractional flow reserve. Anyhow, I'll talk during the course. So I have posed almost 25 questions where I was believing one thing to be true, wherein I have changed my concepts in the recent past after seeing a lot of data, and of course, data has its own limitations. But all the cardiologists, all the physicians, all of us, coronary artery disease is something enigmatic. And some people have one investigation, other people have another investigation. Like, some people prefer this and that. And then interpretation based on the scientific data and trials. So what is the outcome of all these things? And another very important thing, invasive angiogram, we used to do, and I say 40%, and somebody else in Hyderabad says, no, it is 70%, it is significant. Or somebody else in US says, no, it is 65%, wait. We were believing our eyes that, and we were so, no, it is only this much. Now we know that it was our ignorance, whether it is 40%, 50%, or 80%, or 90%, unless it is hemodynamically significant, addressing that lesion is not appropriate. So almost 40 years of blindness in stable coronary artery disease, how the things have been changing, and the debates are continuing. There are longitudinal studies, large studies, wherein there is infighting between the cardiologists, infighting in the groups, committees, trialists, and all. And to the extent that NHLBI, which sponsors most of the research studies, had to come out after the JNC 8 when they released hypertension. Most of you must be aware, physicians. So hypertension guidelines, which drugs, what level, and all. There was committee members and then dissociated, and then they had to drop. And this is an 83-year-old lady now in the social work. She was the editor of New England Journal of Medicine for more than a decade, almost 2 decades. And what she feels, everything that comes into the market, don't adopt the physicians. Something new, somebody promotes. Use your own judgment, not to disregard any scientific trials, but you have to use your own judgment and knowledge before accepting any new thing coming into the market. So in the past 40 years, what my observations, what has happened in practice of cardiology, and what are the blunders and what are the delays in adapting to the newer facts, and the debate, unnecessary debates have delayed in delivering the right thing to the people, resulting in lot of sudden cardiac deaths. I strongly believe that things which should have been adopted a decade ago, these were delayed, and many deaths which have happened in the past decade could have been prevented. I strongly believe in that. I'll show you the evidence. And during our MBBS, whenever you see the textbook, you say significant heart disease means more than 50% stenosis. All other things mild, nothing will happen to you. We used to pat the patients after the angiogram, and sometimes patients used to die within 6 months. So that was the ignorance. Fixing up and only 50% and then playing around that is one of the major blunders. Now we know that is removed. That 50% stenosis is removed. Any CAD, 10%, 20%, 30% is also significant. You have to address that. And then we were thinking about Bayes' theorem, pretest probability, how to screen the patient, which patients need to be screened, how to do, and then based on the age, sex, symptoms, the Diamond Forrester, whatever. Now, based on that, you investigate the patient. Now, you have 6 major traditional risk factors and 200 minor risk factors, because none of these are found to be effective in identifying rightly the patient, and most of these have resulted in over-diagnosis or under-diagnosis. And as I mentioned, the extreme trust on ischemia stress testing has misled all the cardiology community. And why? How? We will see how what the data says. And then arguments, counter-arguments, trial designs, a lot of interpretation bias and confounding variables, measurable, non-measurable, and, hypertension, if you're doing, to practice class versus mass effect, there is no other disease wherein so much of clinical trials are done on hypertension. Enalapril versus this, that, valsartan versus this. Ultimately, we know that it is the level of blood pressure not 140, 150. It is between 120 to 130. You achieve the results, irrespective of the medication, whether it is costly or cheap or whatever. Without much side effects, you leave alone the older drugs. And then variations, as I told, a lot of debates. And yeah, these things. Now, cholesterol controversy, statin controversy, aspirin, something like few terms have come. Metabolic memory, the legacy effect. Should we identify pre-diabetes? Should we identify hypercholesterolemia? Should we identify pre-hypertensive patients and then treat the patients? And what is the age at which you screen? You know, the current recommendation of cholesterol is between 7 and 11 years. First lipid, screening. And then again, second between 17 and 21 years. If there is familial hypercholesterolemia, soon after birth, within a week's time, you have to do the lipid screening. Similarly, pre-diabetes is missed for several years. And then if you identify pre-diabetes and prevent that, and then the metabolic memory at the younger age will prevent future complications. So this is called the legacy effect. So the concept of pathophysiology and the management decision in coronary artery disease has changed tremendously. When I was a student of DM, I was thinking, okay, do the treadmill test, and then if it is positive, the patient is likely to have disease, and if it is more than 60-70% stenosis, fix it, otherwise patient will die. That time, PCA was not there, and then surgery, even for single vessel disease. So now we know, even with the triple vessel disease, optimal medical management in specific majority of the patients, we can manage. And it is not the degree of stenosis. It is the total burden, atherosclerotic burden in the vessel, and the vulnerability of the plaque where it is prone for a rupture. And then a lot of other things which we do not know, as I said, the tip of the iceberg. We do not know anything about the inflammatory status, the genetic component, the epigenetic component, and the thrombotic tendency in Indian patients. How is it different from Asians or Europeans? Even in Europe, there are 4 geographic areas where it is different. Entirely, the coronary artery disease prevalence is different. So a lot of genetic, ethnic variability. Indian patients have almost 2 to 2.5 times higher ethnicity. So now genes are being identified. And if you identify them properly, you can take preventive steps. So handling the cholesterol burden and vulnerability, and handling appropriately with the antiplatelet, the antithrombotic treatment, and aggressive lifestyle changes, including medication, the diet, exercise, all these things are now the focus to control our disease modifying mechanisms. So now we were discussing about 20%. Before going there, this is how the calcium looks. And then there was a lot of debate on calcium score, comparing it with the risk factors. They have stopped this in 1990. In fact, this gentleman, his paper was refused. EBCT, he identified the calcium presence is something different we should. But then it was ignored till 2021. 31 years, it was not given importance, though there is a lot of data accumulating. Because they were comparing, stress test is there, risk factor scoring is there, Framingham or risk score, or PCE, RQ risk, R score, OP, all these European, all these things. So let us first, yes, those are all guessworks. You are not seeing the disease. Whereas calcium means it is disease. It is as simple as that. Calcium score 1 means disease is there. Calcium score 0, I'll talk what it is. Okay, so disease, you are peeping into the coronaries and seeing that there is disease, and you have delayed so long for decade and a half to accept that fact that you don't want to see the disease, you want to guess by stress test or risk factors. That is the major blunder which has happened in the past 1.5 decades. And when this paper was published, people were laughing. What is this warranty and all? How can you do it? Okay, repeatedly. So it took pretty long time for the acceptance for all these studies, longitudinal studies, MESA, Calcium Consortium, all the number of studies, the data poured in. Now people have started accepting this. So another important thing, we know pretty well that what is its importance, we'll see. And as I was mentioning, this concept of subclinical atherosclerosis or plaques is not recent. You see this in 1998, way back, people who died in Korean War, Vietnam War, Bogalasa heart study, children's study, all these, when the people they underwent the postmortem, they found aortic atherosclerotic plaques and coronary atherosclerotic plaques as early as 15 years, 20 years. And if you see this, 60% of the patients around the age of 25 have coronary plaques. It is not 20%. 60% have the plaques. And these are all the, the autopsy studies. And then you have now the recent data is coming up. In 1998 itself, we know. But then we still persisted upon symptoms to occur before we investigate. Now we know the asymptomatic patients, almost 50% of them beyond the age of 40, 45 have plaques. Recently, we had our good friend, orthopedics department in Vijayawada. So he did not have any symptoms. He just felt a mild discomfort for 2 days. And then we saw him, he was having 5 blocks. He underwent emergency bypass surgery, of course. So asymptomatic patients, how to identify, we can address. Once you identify, we can address very easily. Likewise, there are now a lot of SCAPIS study, a lot of registry data are coming up. What percentage of asymptomatic patients will have the disease and how to identify early. Once calcium score is there, it has a definite trajectory, how it progresses. Somebody gets 35, it will progress. Even if you use statins, it progresses faster. So there is a definite trajectory how it progresses. And this is a 27-year-old, non-diabetic, non-hypertensive, has got triple vessel disease. And this is another young fellow with 3,600 calcium score. Unbelievable. So that is why I say it is an enigma and we don't understand why in some people it picks up any genetic component is there. Even in calcium score, yes, there is some evidence to say that. And 70% of the heart attacks occur when the patients have. These are the areas where we admit almost 3,500 patients every year in all our centers across the coastal health corridor. And majority of them do not have any major risk factors. Either they have 0 or 1 risk factor. What does it imply? What does it imply? The patients who is admitted into my ICU today, had I seen him yesterday, I would have labeled him as a low risk category. You won't get heart attack. Don't worry. I would not have started statins or aspirin. I would have sent him away. So this is the data. 88% of the patients with acute cardiac events were classified as low or intermediate risk patients. This is American US standards. Indians have a different risk stratification, which we don't have. Even in US, they were missing. In India, we miss more. So majority of the patients, we have a tendency, I also commit mistakes in the sense in the midnight, I get a call, 2 o'clock, emergency room, patient comes with chest pain, patient has got central chest pain, ECG is normal. I ask, does the patient have risk factors? Hypertension, diabetes? Somehow it gives comfort to me if he doesn't have. But you see the data, majority of them, and application of this risk factor score doesn't have any relevance in emergency room. Chest pain, patients coming with emergency. So this is what 50% unfortunately drop dead or have. And then the rupture doesn't happen, the plaque doesn't happen, doesn't improve, happen in few weeks or months. It is a And then power of zero is talked quite a bit. And the pretest probability, as I mentioned, how the physician perception, we have to change, and it is very, very difficult to predict. And these are the patients with all the risk factors, and TMT positive. And I have done thousands of angiograms where the coronaries are normal, but assuming that the patient will have double or triple vessel disease because he's got treadmill is positive, hypertensive, family is I'll tell you what is the dose he is getting compared to the invasive angiogram. Okay, so these are the things. Of course, in India, entirely the data is different. Even if the patient has a calcium score 0, if the patient has got symptoms, we don't ignore. And we may do either, if the patient can't afford, we do a treadmill test after the calcium score, or we prefer CT coronary angiogram, not to miss any plaques, soft plaques. And now, coming to the LDL cholesterol controversy, statin controversy, and all, these are the things, a weapon of mass misleading. A lot of editorials have, appeared in journals about 10 years ago. I was also confused how much importance it has got and all. But now the longitudinal data, we know that, elevated triglycerides, I was not treating if it is 200. Now I know if anything more than 150, we have to treat even triglycerides. Concepts have changed. This is the latest analysis, 2023. And then the target level of LDL cholesterol. We were talking about LDL cholesterol. So 160 milligrams, okay, leave it. That was the time. 130 milligrams, 115 milligrams, 100 milligrams, 70 milligrams, there is a break. 70 milligrams, you should not go below because brain needs cholesterol synthesis for the brains, or, you will have diabetes. No, it is wrong. Brain doesn't need the cholesterol, serum blood cholesterol. It has its own tissue synthesis. So no neurocognitive impairment. Now, as I will show, the target level for LDL cholesterol depends on how severe is the disease. Mild, moderate, severe, very severe, extremely severe, and even less than 30 milligrams of LDL cholesterol doesn't harm, and it does good. So it is not 70 milligrams. You can bring down based on how the patient tolerates, and the patient has got very critical disease, diffuse disease, nothing else is working, you can't offer anything. Bring down at least the LDL cholesterol. So That is the level. Okay. And then radionuclide, I will not go into the details, but 95% of the stress tests are normal, are uninterpretable, and 50% of the stress tests are done unnecessarily. And that is the reason why Choose Wisely movement has started in US. They stopped reimbursement. The insurance companies have stopped reimbursement unless there are very specific guidelines for the myocardial perfusion imaging, SPECT or PET, whatever you do, which is very frequently done. Almost, I think, 8 million tests are done every year in US. They put a stop to it in the past 1 to 2 years. The insurance company said, no, don't prescribe left and right ischemia stress test. It confuses more often because when you do the test, it is positive. It can be false positive. Accuracy is less. And when it is positive, you do FFR, 64% accuracy. That means it misleads very often. So don't believe beyond a point. So likewise, Indian Heart Journal, treadmill test should not be part of routine health check. So it's not total death of stress test, but there is a way, and you should do stress test when the lesions are showing borderline 40, 50, 60, 70%. You're not sure. Patient gives vague complaints. To correlate it, that is the time. So number of stress tests have come down significantly. It has got its own role, but over usage should be avoided. That is where we are. And then this is a slightly deeper thing. And depending on the moderate ischemia or severe ischemia, we were advising, okay, go for surgery, go for PCI and all. Now we know, based on ischemia also, after some of these test trial results, Courage, Barry 2D, FAME 2, and then ischemia test. Now even ischemic response by our treadmill or radionuclide imaging doesn't give evidence that by intervening, you are going to improve the outcomes. And then more than 400, we were not doing coronary angiogram earlier, but now we know, irrespective of the calcium score, you do the CT angiogram, and then you see the blocks in between the lesions, and then you know what is the diagnosis. So we don't stop, irrespective of the many times, even physicians and all, okay, 400, don't go directly, go for invasive angio. So again, the treatment of silent ischemia, stable CAD is a myth. It is a conundrum from stable to acute. When it happens, we do not know. When the rupture of the plaque happens, we do not know. And then we were talking about diabetes as a CHD risk equivalent. No, all diabetics are not same. I have shown you some of the people, the invasive angiograms, 20 years diabetic, absolutely clean coronaries. So what is happening? It is not all patients. They do not have that susceptibility gene. There is something like an immunity gene. Diabetic gene is different. Hypertensive gene is different. Cholesterol, LDL is different. But they haven't inherited that gene where it causes susceptibility, where there is from the endothelium, the LDL cholesterol grows, or small LDL particles are small in number. You have a large buoyant LDL particles. They don't, even if it is 130 LDL, nothing is happening. Nothing will go into that sub-endothelial space. It doesn't grow. So lot of variance is there, and it is not, it is 43%. So it is not equivalent. Diabetes, don't need to worry. Get the investigation done. Peep into the coronaries. If the patient has got disease, yes, you treat it aggressively. If the patient doesn't have disease, then you target LDL cholesterol to maybe 100 or 70, but don't need to bring it down to 50 or 30, what we do when there is severe disease. So dosage and when you should start. So that also I'll talk. So these are the patients where all the risk factors and the coronaries are normal. Now 30 to 40% stenotic lesions are very common, and aggressive lifestyle measures are quite effective. Yes, true. Yes, true. But then what happens? This is what? Almost 68% of the heart attacks occur in the lesions when the lesion is less than 50%. This is done, this data is known in 1988, but we never paid attention. We started ignoring the 30-40% lesions. Ignoring in the sense, okay, treat hypertension, diabetes, nothing to worry, nothing will happen. But now we know, and all these things, it is not the degree of stenosis alone. It is important, yes, but then the load. Unless it is now evidenced in the past 1 to 2 years by the Scott Hart trial, Iconic trial, Promise study, and now people know that lesser significant lesions, less than 50. That is why the American Heart Association has removed this 50% to say it is significant coronary artery disease. Even 30% is significant coronary artery disease. And this is so the age at which you recommend, this is based on the US studies predominantly, but in India, we have to prepone it by another 10 to 15 years. So this is the average age, 37 years, 40 years, depending on the age and other risk factors. If any patient has got one risk factor at the age of 30, I'll straight away go for CT coronary angiogram. I'll try to pick up, and then some people have 300, 500, I go aggressively. If there is nothing, yes, every 3 to 4 years, you have to go repeat and chase the disease so that you can start the appropriate treatment, by which I'm sure we can postpone the event by another 10 years or 15 years, which is not being done routinely. And okay, you have any symptoms? Okay, keep the blood pressure under control, keep the sugar under control, you are fine. No, it is not like that. You identify the susceptible patient, vulnerable plaque, then you do the appropriate thing. And diabetic patients, you have to repeat at least once in 3 to 4 years. Absolutely no risk factors, almost for 10 years. If a young patient taking all precautions, 6, 7 years, you have to use depending on the patient's cofactors and then comorbid conditions and then how. And the warranty period. Yeah, this is our own consultant whose CT angio was done in 2020. And in 2022, just like that, he got it done. See how it progressed. 95%, it would have been a sudden cardiac death. 95% soft plaque, mixed plaque in the proximal LAD. Our own consultant, he just got it done because I said all the consultants should get CT angio. Though he got it in 20, he's an army person, so he got it done just like that. He got it done. So this is, luckily we could stent. So that is why I tell you, enigma, tip of the iceberg, we can't predict what happens in an individual. I'm very much scared, especially in borderline cases or when, diagnosis is difficult. So this is what calcium score 0 in India doesn't apply. If the patient has got symptoms, you have to go ahead with CT angiogram. Okay. Otherwise you will miss. So many patients, we have the evidence to say that. Now, the other thing, as I told you, invasive angiogram is the gold standard for stable coronary artery disease. So you see this. And after CTCAG, 50% of the patients need. No, stop invasive coronary angiography as the gold standard for diagnosis. This is there in 2015 with the available data. It is not invasive coronary angiogram. The gold standard is a CT, if possible, with the FFR. CT FFR is the gold standard. As I will show you, it is equivalent to invasive FFR, non-invasive. You get vessel-wise, plaque, disease-wise, plaque-wise, you get FFR, and it is very easy for you to take a decision. If the price comes down, that is the test which is the gold standard. For the next 20 years, you can take only a little more advances with artificial intelligence, plaque morphology, which are prone inflammation and all these things. With all these PET scans and all, the information will be there. So likewise, and CTCA, a lot of debate with all these things. So a simple angiogram, I will do. What is the need for CTCA? Anyhow, you have to go. Wrong. 80% of the patients who go for CTCAG do not need invasive angiogram. Invasive angiogram can cause dissections, left main dissections. And unfortunately, we have seen patients, right? So these are the things. And a lot of changes have been happening, but adoption among the cardiology community across the globe, it took almost 10 years, delayed for 10 years. So this is all the data we have. And in acute chest pain, also you can go based on the clinical situation, CTCA, you can immediately make a diagnosis. If the troponin is negative, ECG is normal, echo is normal, send for CTCA. From CTCA room, we send the patients. Earlier, we used to admit for 24, 48 hours, do stress test and all, layered testing. We used to commit mistakes in that. Patients' wastage of time, tension for 48 hours. No. Now, straight away, within 2-3 hours, we make a diagnosis. If it is yes or no, or borderline, we treat. And many patients go home directly from the CT lab itself. So these are all the data which are poured in the emergency room, and then now we have I will not go into the details, and the cost effective, everything is accepted now. And radiation dose, another thing which was planted into the minds of the common man and the doctors is radiation dose. What is the radiation dose? Radiation dose is 50% of the invasive angiogram. If somebody does a radial angiogram, and if we do a CTCA, patient gets double the radiation dose. Apart from that, cardiologist gets, the cath lab staff gets. And in the bargain, we get cervical spondylosis. Okay. So you have to avoid. So it is wrong. Only 50% of radiation dose. It is coming much less even now. So Yeah, this is all the data, what you have with step and shoot technology, a lot of iterative reconstructions and all. Now, statins and aspirin. This is another important thing for clinical practice. Statins, when do you start? Most of the times, the average age at which we start statins when they develop a coronary artery disease around 55, 60 or 65. No, by the time already plaques have formed. Statins should be started early when the cholesterol plaques are spongy and when you can expect some regression and plaque stabilization, the cap becomes thicker so that it won't rupture. So if you have to start statins, appropriate dose. Inadvertently, we see some people straight away statin, clopidogrel, aspirin, just like that on suspicion. You should never do that. That you're harming more. Identify the disease, based on that, pick up the right dose, right statin, and again, the aspirin controversy and all. Yeah, as I mentioned this, blood thinner, aspirin for primary prophylaxis is out, except in very, very specific conditions. I used to give aspirin. We were giving a smaller dose, only 75 milligrams, but people were receiving 150 milligrams for decades together in the past. Even doctors were taking. In the bargain, they were having bleeding, GI, more harm than. So aspirin is not there. And even aspirin after post-PCI patients, most of you, now we stop after 3 months or 6 months again, based on the bleeding risk and then thrombotic risk based on that. So aspirin role is coming down. If at all you have to give, still neurologists give a little higher dose, but we have documented evidence that even 75 milligrams is good enough in majority. And when you combine with clopidogrel or ticagrelor. So this is what the LDL cholesterol and the levels, as I mentioned, 30 milligrams also. This is all the latest National Lipid Association recommendations. And these are the top 10 messages after which CT coronary angiogram, calcium score are accepted as first-line investigations. Invasive angiogram is pushed down. Ischemia stress tests are pushed down. And this is what? Class 1 indications for stable angina pectoris in chest pain patients. In moderate disease, if the patients develop symptoms, again, whether there is any progression. So these are all the indications for this. So why delayed? It took pretty 10 years. American Society of Nuclear Cardiology is a very strong lobby. And when these guidelines were put, they were in the committee. They came out when the guidelines were released because they didn't like the guidelines. So lobbying plays quite a bit even in giving scientific evidence, proper scientific evidence and benefit to the society. I strongly believe that it was stopped. And I was talking to some of the people in US also. They have deliberately stopped this being utilized by many people, wherein, as I showed you the numbers, the figures, the people who died, many of these deaths would have been prevented. And so CTCA for diagnosis, cath lab only for interventions. So this is what it is. But whatever data it is there, still we are ignorant about the microcirculation, microvascular disease, epicardial collaterals, endocardial collaterals, how it happens, how in some people there is a beautiful collateral formation, why it doesn't happen, I don't know. Why some people antiplatelet drugs are effective, some people it is what is the dosage, who develops complications, still there is not enough data. This is a mixture of, atherosclerosis is no more, it is not a lipid storage disorder. It is an active inflammatory process where there is lipids, macrophages, monocytes, immune response, inflammatory response, and thrombotic tendency. So this is what is realized now, and still a lot of things. So the dream now, certain terms like cardiovascular risk and socioeconomic mobilization. When you start the treatment, the data, what was there in the longitudinal studies gets modified because the patient follows, some people follow, then the disease process will be modified, the outcomes will modify. Then the financial toxicity. You're talking about, catastrophic health expenditure and all. So these are the things where if you understand and apply the available investigations appropriately, you can bring down health budget in India, 1.15% of the total budget of the GDP, whereas it is 16-17% in US, right? Indians person spends $40 per year, whereas Americans spend $8,500. How many times? It is 200 times, right? So this is where very poor allocation of the funds, poor understanding, poor healthcare seeking attitude in Indians, poor education, and accountability of the doctors who are watching this. So this is what there is a lot to talk about and still a lot to learn about, but apply whatever available evidence is there, apply to an individual patient, because no size fits all. And you have to use your discretion in addressing a patient when you see a patient, because any department in your future, till you practice medicine, cardiology is a very, very important topic. A patient comes with chest pain, patient comes with palpitation, patient comes with syncope. You should know at least the basics, how to read the ECG, how to evaluate, what tests you should believe, how you can interpret, rather than depending and then getting confused with the 2-3 cardiologists, different opinions. And you should not get, you should have the basic knowledge. So this is what finally I think, and thank you for patient listening. And before